Symons is our next presenter. She's a clinical nurse specialist at Box Hill Hospital with a keen interest in quality and safety. She's presenting on something that's incredibly, I suppose, relevant at the moment. I don't think there's a place you can go without you don't see a sepsis kills bomb, or you hear a story about sepsis, or somebody's not doing a sepsis project. And despite all the initiatives over the last 10 to 15 years, we still lose patients who aren't particularly vulnerable to sepsis. And so I'm excited to hear how she's improved the early identification and management of sepsis, and how she's implemented an evidence-based screening and treatment pathway. Come.
It's all good, thanks. Okay. So, yes, my name's Meredith. I am a CNS at Box Hill ED. Thank you for allowing me to present this afternoon. And yes, just showing you about our project on improving the early detection and identification and management of sepsis, and what we think has so far been a successful implementation of an evidence-based screening and treatment pathway at our organisation. So, as we all know, sepsis is a medical emergency. It's the primary cause of death from infection, especially if it's not recognised and treated promptly. It's also the leading cause of clinical deterioration and accounts for about 30% of adult hospital MET calls. And even in 2012, ICU sepsis mortality in Australia and New Zealand was still 18.4%. So research, as we know, shows that early recognition of sepsis and timely antibiotic administration can really enhance patient outcomes and reduce mortality. So just a little bit about Box Hill Hospital and Eastern Health, in fact. It's a large multi-site public health service in Melbourne's eastern suburbs, comprising three acute hospitals, adult and paediatric, 2 subacute hospitals, day surgery hospital and satellite dialysis units. So what we did, we found in our organisation that there were barriers to early recognition of sepsis and to administration of antibiotics and IV fluid. We saw that there were staff knowledge deficits, there was a lack of a consistent application of well-recognised guidelines, such as those set out by the Surviving Sepsis campaign for best management of these septic patients. As we all know, unlike something like AMI, sepsis is very difficult to diagnose. There's no gold standard test. Not all patients are going to have the classic SIRS or QSOFA criteria, and clinical diagnosis is often reliant on the clinical expertise of the experience and expertise of the clinician, and also having a high index of suspicion when you're interpreting patient history and their presentation. So we really felt that there was room for improvement. We did performance monitoring, we had stakeholder meetings and benchmarking, and it showed that there was definitely room to improve our identification and management of these patients. And we felt that this could be best achieved through the introduction of evidence-based sepsis guidelines and through standardised screening and treatment tools. So our objectives, pretty straightforward really: enhance clinician skills in sepsis recognition and treatment, ensure that there was timely and appropriate sepsis management occurring, and in the long run, reduce patient hospital length of stay, morbidity and mortality from sepsis-related conditions. So our method, the Improving Sepsis Recognition and Management program was a quality improvement project. We used Plan, Do, Study, Act cycles, and with permission, the New South Wales Clinical Excellence Commission's Sepsis Skills program that we've referred to was adapted to align with the Eastern Health Clinical Emergency Response System. Sepsis pathways and worksheets were developed for adults, children and neonates for both inpatient and emergency departments. And the program was piloted at the Angus Hospital site in November 2014, and then it was rolled out to all our acute Eastern Health sites, including Box Hill, in July of 2015. So what did we do to try and create change? Well, we engaged clinicians. We appointed a steering committee, site project leads and department sepsis champions. We did a retrospective baseline audit to make sure that to establish the appropriateness and the timeliness of the proposed evidence-based guidelines, and a new algorithmic pathway and worksheets were developed and disseminated. We collaborated with the Eastern Health Antibiotics Stewardship Committee to make sure that antimicrobial guidelines aligned with the latest evidence, and we spoke to pharmacy to make sure that there was available and timely antibiotic administration occurring. Education occurred through Sepsis project interactive presentations, through resource folders, intranet guidelines, and also through copies of the pathways being made available at the patient bedside. We also established a regular communication with staff through the World Sepsis Day promotion, through weekly newsletters, emails, and through display of posters such as the little one you see here, courtesy of the CEC Sepsis Kills program. And in emergency specifically, we brought in an electronic sepsis pathology order set, which also had a pop-up antibiotic prescribing alert. We fed our audit data back to clinicians on a regular basis to try and encourage them to engage in practice change. And we also created a little paediatric lanyard which showed all the abnormal vital signs for a quick reference for staff. We ran a cross-site ED sepsis screening challenge in about September of last year. We also participated in the 2016 Emergency Care Clinical Network Sepsis project, and this gave the project team further impetus to meet and to engage in PDSA cycles and compare our results, share our lessons learned and plan for future advancements. And in our last round of audit, we also tried to engage a number of medical and nursing staff to try and encourage that ownership of successes and also make them aware of areas for improvement. So time is limited, but I did want to show you our worksheet. This is the adult sepsis worksheet. So just going through the steps, and I'm sure you've seen similar forms to this floating around, but this was based on the CEC form. And obviously the first step is to recognise these patients. So we need to look for the common risk factors and signs and symptoms. We need to look for orange criteria, so abnormal vital signs. If there are two or more of these, we're then looking to see is there an additional purple criteria, for example, low blood pressure, and then are they septic? So if there are two orange and one purple, we can assume until proven otherwise that this patient has sepsis or septic shock. So then we need to respond. We need to escalate these patients. Sorry, I'll just catch up. And we need to, if they're not already in a high acuity area, we need to consider moving them there, get a senior clinician review immediately. If they've just been triaged, what's their triage category going to be? And also, do they have an advanced care directive? Is it appropriate for us to aggressively resuscitate this patient? If we then look at the reverse side of the form, this is our Sepsis 6. This is our resuscitation phase. So I think you're probably all aware of the Sepsis 6, but oxygen is our first step if it's required, taking blood cultures and any other pathology, taking a lactate, giving IV fluids, giving a bolus, and then most importantly, IV antibiotics, empiric antibiotics until we know the source or that have cultures with sensitivities, and monitoring these patients for improvement or not improvement. And then we need to reassess, constantly reassess, and then refer as appropriate to ICU, etc. So that was our form. And then the results of our audit. So we conducted retrospective audit, chart audit over 3 periods, so prior to the implementation and then 2 periods post-implementation. You can see the numbers there. I won't go through all of it, but you'll see from the number of patients who are discharged with a sepsis diagnosis, these are very small numbers, but they're still important patients. So the audit numbers are small, so it's hard to draw big conclusions, but I can show you that the trends are promising in terms of our treatment. So you can see the mean patient age is roughly the same for each group. We found that there were no paediatric patients in any of these cohorts, but we do screen our paediatric patients, and we do encourage everyone to do so. But looking at the audit for June 17, the numbers are smaller because it's incomplete, it's still underway, but we've seen an increasing number of patients actually identified as septic. Now, whether that's just because we've got more patients coming through, we've had a massive increase in presentations to our ED, as I'm sure every other hospital has. But is it that we're actually identifying these patients more readily? The patient arrival mode, I think, was important because you can see from the 2017 data that almost half of our patients that are septic are walk-ins. So we need to be really aware of these patients, and I'll show you a graph shortly that shows there's a discrepancy in time to treatment for those two groups, which was no great surprise. And if you see with the triage presenting problem, we brought in the query sepsis problem in August 2016. You can see that 58% of triage nurses are actually using this to flag the patient as potentially septic, and that's really good because it's a really important step. It's there on the screen. People can see that this patient needs urgent attention. So that was a useful step, I think. So the data, the results. So with the Sepsis 6, oxygen is consistently well given, which is good. So I haven't got any charts regarding that. And also monitoring. We are monitoring these patients very well. So if you look at the other four treatment elements, blood culture's being taken. So we're doing quite well there. We were doing well before we started the project, which is good, but it's been consistently high. It's at 92% still in 2017. I did want to show you the patients that are having at least 2 sets of blood cultures taken, which is best practice, as we know. This does include patients across the entire hospital journey. So often we're not getting to do 2 sets of cultures in ED before we're giving antibiotics. So these are patients, as I said, across the whole stay, and it's still quite low, but it's actually improved dramatically over since we've implemented the project. And positive cultures I thought was interesting as well, because we talk about the fact that there's no sort of gold standard test for septic patients, and even with the 2017 figure there, you can see only 55% of patients have a positive blood culture, so we can't use that. That's why we need to screen and be alert, and not to mention the fact that these results can take days to come back. If we look at lactate, so we have had an improvement and then a bit of a drop-off. So the drop-off we're sort of putting down to potentially, we've brought in a NUTS project in ED, which is a no unnecessary tests initiative in the last couple of years. So lactate, as we know, is a measure of sepsis severity, but you could argue it's useful, but it's not necessarily required always for diagnosis and or to guide management. So that was interesting to see where we are with that. IV fluid, thank you. IV fluid, again, it's dropped off a little bit, and I wonder if perhaps there has been an increase in inotrope use early, and also this doesn't take into account the patient's comorbidities, CCF, that sort of thing. So I think we're being a bit more cautious with our IV fluid resuscitation, which is also probably good. Antibiotics, so we obviously we know that the target at the moment is still 60 minutes to antibiotics. There's other research that indicates there may not be such severe adverse effects for a delay in time to antibiotics, but that's still our target. And if I show you the time to antibiotics, we're not quite hitting that yet, but we have improved. Sorry, I'm having to skip along a bit. And also if we look at our percentages for IV antis within 60 minutes, so we started at 11% and we're sitting at 27% at the moment, so slow improvements. Hospital length of stay, we have sort of stayed pretty much the same according to our ED audit. If we look at mortality, it's still very high. It could be that patients obviously in emergency are often a lot sicker than they are, say, on the ward, and I'll show you the hospital mortality, which has actually dropped. But interestingly, we have found that patients who don't have an NFR, we found in the 2015-16 data, 14% of patients who were for full resus still died. So we do have to look at was there something that we missed there, or were they just sicker patients? The ECCN data shows an improvement, so you can see across the points there for IV antis, IV fluid, initial identification of septic patients at triage. We've made some good improvements. The mortality has gone up, though, according to this very small sample of patients. And again, we need to look at sort of why was there a higher acuity with those patients. But we're talking about, under 20 patients in the sample. If we look at hospital length of stay, as I showed you before, it was quite consistent in the previous data. With this one, we got a much higher starting point, though, at 9.5 days. Was the average length of stay, which came down to 6. So we could say, yep, that's really good, but we know that there was quite the mortality actually went up. So was it shorter because these patients passed away? But we look at the trend; it's an improvement. So that's good. Just very quickly, time to antis by arrival mode. So you can see the discrepancy there. So walk-ins almost double sort of the time to antibiotics, again with the small sample. So we need to be aware of these patients. And the worksheet use, I'll just very quickly show you there. It could be a coincidence, but we did find that worksheets are only being used about a third of the time. And when they are used, according to the data that we've collected, the time to antibiotics is much quicker. So whether it's just having the worksheet there, knowing about the worksheet has certainly improved things, but possibly actually using the worksheet will increase those times, drop those times to antibiotics even more if we consistently use them. Something to think about when we're about to go digital as well. We are keeping the worksheets for now. If we quickly look across all sites, just shows that we've got an increasing number of patients being coded as septic, and we think that that's because we're identifying these patients more quickly and more frequent, and acting more appropriately. And also there has been, I don't have a graph, sorry, but there has actually been across the hospital a 50% reduction in hospital mortality. So these are largely the patients that become septic on the ward and go to ICU. I think that's why there's a difference between the ED data and across the hospital data in that respect. And we're also needing to ventilate less patients, which is great. It obviously has flow-on effects for budgetary effects, which is awesome. And also with length of stay. So we have had a decrease in length of stay if you look across all sites there, which is really good. Definitely helping our flow a great deal. So what have we learnt? We've learnt that implementing an evidence-based sepsis pathway is really enhancing early detection and management of sepsis and improving our patient outcomes at Eastern Health. And our audit data, despite being quite limited, actually indicates encouraging trends in standardised care and clinician capability in sepsis recognition and treatment. PDSA cycles and being involved in the ECCN sepsis project has allowed us to highlight areas for revision of pathways when we are currently revising our pathway, and also areas for further education. And engaging staff in audit and feedback of data showing both our gains and our areas for improvement empowers staff to sustain practice changes. Just my references, and thank you.
Thanks, Meredith, for an excellent presentation.
Thank you.
I just have a question about, I saw that you presented data on the number of patients that were had diagnosed with sepsis discharge. Have you had any way, have you looked at the number of patients who have been missed kind of from triage, I guess, that met the criteria for the pathway?
Not specifically. I would be interested in doing that. It's quite difficult to follow these patients up. But I think, I did do a small audit. I think it was last year that I think we found that we weren't really missing any, which is great. I think what we're finding is we're getting a lot of false negatives, which is fine though, because we'd rather be over screening and over assuming that these patients are septic. If it turns out that they're not, so be it. But it's I think we're actually doing a pretty good job of actually picking up all the ones that actually are, which is good. I don't have any data for you. I'm sorry, but yes, I think.
Figure out how to identify it at the beginning. I was just wondering if you had any tips.
Yes. I didn't have time to show all the data that I've got in terms of more frequent criteria that are appearing, so orange and purple criteria and that sort of thing. But we do find that if you follow the Sepsis 3 definitions in terms of the QSOFA, but being fairly predictive, but also you need to look at the risk factors and the signs and symptoms. And there are signs and symptoms and risk factors that are more frequently coming up. So that's where the screening pathway, I guess, has helped us, because it is fairly accurate. It covers sort of all of those elements. If you have just this, the SIRS alone, they're not specific enough, sensitive enough, or specific enough. So it's that combination, I suppose, of having the risk factors and signs and symptoms, as well as your criteria, and having a strong suspicion, and looking out for any deterioration. Yeah. Thank you.